an hour or so that it will be fruitful. Come on. So Dr. Piyush, can we start now?
Okay.
Dr. Piyush, you are mute. Please unmute yourself and start the presentation.
Sir, am I audible now?
Yes, you are audible. Please go ahead.
Good evening, sir. Sir, today I am here to present the clinical case discussion on the carcinoma buccal mucosa. So, sir, shall I start?
Yes.
Okay. So, she was Mrs. Kavita Samal, a 56-year-old lady residing in Behrampur, who is a local grocery shop owner by occupation, presented to Radiation Oncology Department OPD on 16th of August 2025 with the chief complaints of non-healing ulcer in the inner aspect of left cheek for 6 months. Coming to the history of present illness, the patient was apparently asymptomatic 6 months back when she developed a non-healing ulcerative growth in the inner aspect of left cheek, which was insidious in onset, gradually progressive from a size of P to present size 1 rupee coin. The ulcerative growth was initially associated with non-radiating, mild, burning pain, mostly during daytime while eating, and it was 3-4 months back. And now the lesion is completely painless. The lesion is associated with odynophagia. There was history of multiple similar lesions in the past at the same site, which usually heal on their own. History of excessive salivation was there. There is also was a history of sharp lower left tooth. No history of difficulty in opening mouth. No history suggestive of leukoplakia or erythroplakia. No history of loosening of teeth. No history of difficulty in movement of tongue or soreness of mouth. There was no history of hoarseness of voice or change in voice or difficulty in speech or swallowing. There was no history of any other swelling in the neck, and no history of ear pain, no history of fever, chronic illness in the past, or significant weight loss. There was also no history of cough, breathlessness, hemoptysis, any pain in the bony sides or abdominal distension or joint.
So Piyush, I'll interrupt over here, Can you go back to your first slide now? Yes, so you mean to say, what do you mean by cheek, I mean?
Cheek with respect to I mean to say the inner aspect of the mouth, sir.
Inner aspect of mouth. You mean to say, in a scientific term, do you mean to say buccal mucosa?
Yes, sir, the buccal mucosa.
What is the boundaries of buccal mucosa, Dr. Piyush?
Sir,
How will we understand this?
Sure, sir. The buccal mucosa is bounded anteriorly by the commissure of lip, posteriorly by the retromolar trigonal area, superiorly by the palates, and inferiorly by the mandibular or the floor of mouth.
It's not by the palate, Dr. Piyush, like I recommend everybody to always go through the textbook. If you see the buccal mucosa boundaries in the peris, it has a boundary. What do you mean by boundary? It just mentioned that cheeks, cheek is a term over there also, but what is the boundary, The anterior boundary is basically what you told us the.
Sir, lip commissure.
It's not the lip commissure, basically the contact of the opposing lips. That is it. So it's the angle of the mouth, you can say, but exact terminology is contact of the opposing lips. What is the posterior boundary did you mention?
Sir, I mentioned RMT, retromolar trigonal area, sir.
It's not a radiomandibular trigone. It is basically a pterygomandibular raphe. That is the posterior boundary. And the superior and inferiors are basically by the upper alveolar ridge and the lower alveolar ridge. But moment you enter into the palate, you are crossing, because you are crossing the alveolus and there you are coming to the palate. So it has to be a upper and lower alveolar ridge. Posteriorly, it is by the pterygomandibular raphe, and anteriorly where the contact of the opposing lips. So that is the thing, And so having said that, even your history in which you have mentioned the non-healing ulcerative growth in the inner aspect of the left cheek, which was insidious in onset, gradually progressing in size of P to present size of a 1 rupee coin. And still, I'll recommend that instead of mentioning these terminologies, though some histories they do mention the P and the size, but if you can just mention size, approximate size, what the patient has said, because a
Okay.
patient who is from Behrampur, who is a grocery owner, might not be so conscious to say that ki 1 rupee coin, because this is not the term which they use it. In fact, I had posted this history prototype in which it has been written in this form, but still I'll prefer you to say some kind of a size actually. Then the lesion is associated with odynophagia. Why do you think that there's a odynophagia straight away?
Sir, there was
The reason
actually
why I'm asking, if any patient, whether from a rural or a urban background, if they have a problem from 6 months with an odynophagia, they will present even before. Because pain is a symptom where everybody gets conscious and they will visit the clinicians or at least the local health center. But if the patient had a odynophagia and 6 months still she's sitting somewhere without attending, your history really doesn't matches him. Though you have written it while eating 3 to 4 months back and now the lesion is completely painless. So you mean to say that initially it was painful and now it is painless?
yes, sir.
Okay. Does everybody agrees?
Initially painless and painful.
Sorry?
Initially, it should present as painless and then it should be painful.
Rather
Once.
that
Maybe just burning sensation.
yeah, right. So initially, I think that is absolutely right. Initially, it's painless. Later on, it becomes painful. Rather than initially it was painful and now, if you say this, you have to justify in DNB examination. Examiners, by and large, I say everybody is very cooperative. Anything you can say, no doubt about it, but then you will have to justify. Dr. Piyush, can you say that when initially it was painful and later on it became painless, there can be a condition. There are conditions in which it becomes painless. When? If the lesions is so advanced that your inferior alveolar nerve gets involved, when your inferior alveolar or the mandibular nerve, when it gets involved or when it gets damaged or when it gets really involved, in that case, the innervation might be lost and then it can become painless. So then your history then should be later on also should be matching. If it was initially it was painful and later on became painless, then inferior alveolar nerve was involved and that is the reason why it became painless. So you have to justify that also. Okay. Why there was a history of excessive salivation? What can be the reason?
The history of excessive salivation is supported by the fact that the lesion was actually irritant in nature.
Good, very good. And there is no history of difficulty in opening the mouth. What does it mean?
It means that there was actually the surrounding muscles have not gone into the spasm, or the lesion has not actually infiltrated the muscles to cause the
Anything else which is more common, which will be less, which will be expecting a more common reason rather than the involving of muscles involvement can be there, but anything else?
in response to pain also.
No, I'm asking that if there is not an adequate opening, I think already it's coming into the chat box. It's very good. The people who have written it submucosal fibrosis or OSMF, that is oral submucosal fibrosis, will be the first reason, because any kind of an addiction will be causing submucosal fibrosis upfront. Then all those reasons like muscles involvement, pterygoid muscles involvement, or other muscles involvement, what you have said. So primarily it will be a oral submucosal fibrosis, which will be leading to a inadequate opening of the mouth. Okay. Other reasons what you have mentioned is fine, that muscles involvement. And specifically, which muscles are you talking about?
The muscles of mastication.
Which muscle?
So the medial or lateral pterygoid.
Medial or lateral pterygoid, correct. What are the muscles of mastication?
Sir, there is the temporalis muscle, which is on the outermost aspect of the mandible, lateral side, and I'm actually starting from the lateral to the medial. So then it's surrounded by the uh, temporalis muscle, then it's the masseter, then the lateral pterygoid, then the on this aspect is the medial pterygoid.
Okay, fine. Then no history of leukoplakia and erythroplakia. What is leukoplakia and erythroplakia? These are the
So these are the specific conditions in the oral cavity which we encounter. The leukoplasia is a whitish patch, and the erythroplakia is basically the redness of the buccal mucosa.
are they what? What do we
So
call
they are
them?
the pre-malignant lesions, sir.
Oh, they are pre-malignant lesions. There are two things which is very important: leukoplakia and erythroplakia, which is more propensity of causing carcinoma, leukoplakia versus erythroplakia.
The erythroplakia has the much more higher chances of about 30%, whereas the leukoplakia has the chances of about only 4 to 18%.
So in exams also, Piyush or when for everybody, when examiner asks, just answer that much, how much he is asking for. Unless and until he doesn't ask you the percentage, please refrain from saying. It might happen that your percentages are not right. And as what you have mentioned, because even in leukoplakia, the leukoplakia chances, what you told, 4 to,
The leukoplakia 4 to 18%.
I am not aware of that, how much percentage it is, but you might just check it if you're so sure. But in erythroplakia, the Perez mentions that in erythroplakia, if there is a homogeneous erythroplakia and if you biopsy it, there are almost 51% chance of having invasive carcinoma and nearly 40% chance of having carcinoma in situ. So that much chances it can have in a homogeneous oral erythroplakia of having carcinoma if it is biopsied histopathologically. So unless and until, or give examiner a chance to ask you. Question is just which has a more, to just say कि erythroplakia has a much higher propensity than leukoplakia, and let him ask कि, do you know the percentage? Then go ahead. Otherwise, please refrain from it, because in this way, what happens कि you will also get a chance of answering, and examiner has a chance of putting the next question. Okay.
Sure.
Okay, fine. Let's move to the next slide. Okay, fine. So these are all the negative histories.
Yes, sir.
Any input from anyone? Anybody want to add anything? Why do you say that no history of ear pain? What do you mean by no? Why there will be a ear pain?
Because of involvement of auriculotemporal nerve, sir.
Is it more common in buccal mucosa or it is more common in any other subsite of oral cavity or any head and neck cancer?
Sir, the tongue, sir.
Particularly which tongue?
Based.
Part, base of the tongue, base of the tongue. I'll again be sure that what is the sensory distribution and what is the motor distribution of the tongue. But base of the tongue has a referred pain, and through which nerve particularly?
Auriculotemporal.
Auricular.
Branchomandibular nerve.
I am not sure. I'll have to just check once, but I think it is a glossopharyngeal nerve.
Glossopharyngeal.
Glossopharyngeal, correct. So that is what I remember, glossopharyngeal nerve. It is also called as nerve of Arnold, I suppose, so to just check that,
So
but I think it's
Jacobs.
glossopharyngeal nerve, Jacob's nerve. Now, what do you mean by no history of fever, chronic illness in past? How does chronic illness in past helps you?
Sir, actually, by this point, I needed to rule out whether the patient was having the history of or had the history of tuberculosis or not.
Okay, fine, fine. Weight loss, poor oral intake, no history of cough, breathlessness. Fine, okay. What does it says? What does it signifies?
Sir, by meaning of the negative history for the involvement of the lung system, I just wanted to rule out that whether there is no history of metastasis to the lung, sir.
Absolutely fine. Yeah, absolutely fine. So, Dr. Piyush, you have done a very good job. I'm just asking because I know that you are already aware of it, but just for the sake of you are really aware. What is the percentage of having a bony metastasis so that bony pain will be there?
Sorry, sir, I'm not aware of that percentage,
No
sir.
problem, no problem. You everything in exam you don't have to know. You can just very silently you can say in the exam, sir, it is relatively rare, sir. Examiner is also not knowing the percentage. I can vouch for it. Most of the
Okay.
examiners will not be knowing the exact percentage. It's not possible. So you just say that relatively very rare and that will suffice. If examiner really wants can you guess something, then you can do so because he himself is asking, can you guess something? There are fantastic examiners in DNB who will make you to answer even something which you even don't know. So they make you feel so comfortable. So instead of saying that I don't know, you can just give it a guess that, "Okay, sir, it's relatively much rare, sir. That's all. How much it is, sir, I'm not sure, but sir, it's very rare. Bas. Okay, finish. That's all. Okay. In
Okay,
which
sir.
site you are thinking that the abdominal distension or a liver metastasis can happen? In which particular subsite of head and neck? Liver mets and bone mets.
So they are particularly associated with the nasopharyngeal carcinoma.
Esophageal carcinomas. Very good. Come on. Next slide, please.
Sure.
Very good.
Sir, sorry to interrupt. Can I ask a doubt, sir?
Yeah, please.
Sir, in the history of presenting illness, should we mention the history of presenting illness in layman terms or medical terms, sir? Because we are eliciting the
Oh,
history of
so
presenting illness.
yeah, so very good question. What happens like usually presenting complaint always happens in the patient's language. History of presenting complaint, it's a kind of it happens a kind of it is usually in a modified form where you try to make the examiners understand. So it's a kind of a mixture where you take both the aspect, but definitely it is not completely into the patient's language because otherwise if we say insidious in onset, the insidious patient has never said insidious. He has said that from many months. Presenting complaint, it is always in the patient's language. History of presenting complaint, it can be a language which is more easier for me to explain. So that will be a kind of a scientific as well as the mix. So it's a lightweight, and that is the reason why it has been written from the size of the pea to the size of the coin. So either of the things are right. Okay.
Thank you,
Yes.
sir.
Please
Sir, I
talk.
also have a doubt.
Yeah, please.
Since in this history it was mentioned that patient had like odynophagia, like she had a like pain. So like we are supposed to mention that in the presenting complaint also, right? Like we
Yes.
need to, yeah.
So,
And
so,
maybe excessive
only,
salivation also if the patient would have told.
so only thing is that it's generally a dictum that you try to keep presenting complaint as simple and as minimal as possible. Because what happens if we go on saying that here the primarily we wanted to say that ulcerative, like there is a growth inside the cheek, that is one from last this many months. And then you want to describe all those things in the subsequent slide. So you can avoid it. So
Okay.
moment you become very extensive, like 2 to 3 cardinal symptoms will be enough. But beyond that, you should just refrain and keep everything in history of presenting complaint. Otherwise it becomes too long actually. Okay.
Okay, sir. Yeah.
Very brief to keep your presenting complaint.
Okay, sir.
Please.
So shall I continue?
Yeah, please.
So I'm just coming to the past history. I've actually compiled all the histories over here under the slide. First, going by the obstetric history, that is the para 2 and living 2. All the child were born by normal vaginal delivery. The last childbirth was 32 years back. The date of last menstrual period was on 30th of July this year. The medical history, the patient has a known history of hypertension since 15 years, and she is on medication of the telmisartan and amlodipine with the doses of 40 and 5 milligrams respectively, and the patient is compliant for them. There is no
Patient
history
is
compliant for them.
okay.
There is no history of diabetes mellitus, asthma, or tuberculosis. There's no history of radiation exposure. In the surgical history, the patient has a
Piyush,
history
how
of
does the history of radiation exposure?
it will actually guide whether the in the mainly in the sir, management part, sir, and some
What?
symptoms maybe also be there.
So in medical history, there is not only the treatment part. You're not talking about a re-radiation or something like that. Your terminology is very simple. No history of radiation exposure. The reason why is this important is that the patient has received any prior radiation or not, because we are thinking in the terms of mainly first thing is that radiation induced malignancy or the secondaries, secondary malignancy because of radiation. That is the reason why you want. Re-radiation is the second part you will take care, but primarily you are looking into the concept that whether the patient has taken any kind of a radiation in childhood. Most commonly, you can say lymphomas, where the low doses of radiations are given even in childhood. So that is causing the secondary malignancies over there, and that is basically a mutagenic, because it can cause mutations actually, and that is leading to your secondary cancers. Okay, so for that reason, and usually the radiation, what you are talking about, re-radiation, they are the ablative doses. So there is a mutagenic doses and ablative doses. So here, basically, radiation-induced secondary malignancies, which you are looking into it. And also, I think, so this you have to keep it in mind. That is the reason why you want no history of radiation exposure. Okay, proceed.
There is also a history of a road traffic accident back in the year 2017, for which she underwent a right foot amputation.
Fine.
Coming to the personal history, the patient consumes mixed diet and preferably the spicy food. She is educated till 5th standard, widowed. The history of chewing quid, the betel quid, since 40 years, 5 to 8 times a day for 10 to 20 minutes each time, mostly on the left side of the cheek. She doesn't keep the quid while sleeping. The history of smoking BD,
How
the
does it
country
make a difference? Again, I'll request everybody, anybody can chip in and ask the question to Piyush, because that will be helping us. Sharp will end by 9 p.m., and then so we have just another 28 minutes to go. So please keep on asking. How does it helps in quid while sleeping? What is it happening?
by actually this I just wanted to see that whether in during the sleep the flow of saliva, so there may be the feature that the swallowing reflexes may be reduced and there's a chances of aspiration.
No, that is not. I think everybody has written continuous exposure. We know that it is a continuous
Continuous irritation because prolonged
Contact irritant.
contact irritant, but still I'll be expecting a much better answer than that. What happens, you are absolutely right. Irritant for a prolonged exposure, everybody is writing, but you have to understand that this tobacco, after it gets in combination with the bacteria of the saliva, it has a reaction and it produces a nitrosamines. These nitrosamine chemicals are basically the irritants, and these irritants basically with a prolonged exposure, it can convert, it will have a high chances of making into a pre-malignant condition and later on even malignant condition. So basically nitrosamines, because of the quid, chemicals in the quid and the bacteria in the saliva combining together. So nitrosamines, okay?
Also,
Next, please.
there is a history of smoking BD, the country made cigarettes in 20 years, 4 to 8 per day. The values coming out of smoking BD years was 2.3 to 4.6. There is no history of reverse smoking.
Pack years then?
There is no sorry,
Can you find pack years in this?
sir, actually, sir, it would be much difficult because the
Difficult to calculate, but
BD
it will be but I think it is difficult in the case of BD to calculate the pack years basically.
yes, sir.
Okay, fine. And if it would have been a cigarette then, with the same amount what you mentioned, how much it will be the pack years?
Then It would be around 5 to 10, sir. 5 to 10 smoking pack years, sir.
And how have you calculated that? Does
Sir,
everybody
I've just
agree? 10 cigarettes for 25 years, every day it will amount to how many pack years? Ankita, are you there? Ankita Lahiri? So Bhagya has mentioned 12.5.
Yes, sir. 10 by 20 into the number of years of the smoking.
10 by 20 into the number of years. Fine. So I think Bhagya is right. Jyotirmay is also right. So everybody is right. Good. Okay. No history of alcohol. Say me, Aditya, you say me that history of alcohol. How does it makes a difference? Is alcohol carcinogenic?
hello. Yes, sir.
Yes. No, I'm
Uh,
asking.
Indirect
not
carcinogen.
indirect, sir. Like maybe due to the
Synergistic action.
What do you mean by synergistic action?
when used combined with smoking.
So what does it causes? Mucosal damage. Mucosal damage.
Yes, sir.
Okay.
Yeah.
So because of mucosal damage, that basically the preventive layer goes off, and then after that it will be causing as an irritant and thereby predisposing it to the A. Okay. So it's basically a synergistic effect. Absolutely right. Normal appetite, normal sleeping habits, normal bowel. Come on, next slide. Okay.
Sure, sir.
Okay.
So coming up to the general physical examination part, the patient was conscious, cooperative, and well oriented to time, place, and person. The patient was properly assessed only after obtaining proper verbal consent in the presence of natural light with adequate privacy in front of female attendant. The assessment was done as follows. The height
Did
was
you want the patient lying down, or you were sitting on a chair?
she was actually sitting on the chair, sir.
Mention that also, properly assessed, and properly assessed. Again, you written proper. So don't repeat the words, the patient was properly assessed, adequately assessed, okay, with a
Okay.
valid verbal consent. So use your term, use your English also very carefully that what languages are using. Also write the patient was in the seen in a sitting position.
Okay, sir.
Do you require a female attendant for examining a patient?
Since the patient is since my patient is female, so I asked for the female attendant.
Varsha is saying yes. So if Piyush examines a female oral examination, will he require a female attendant in front of him? Nikhila is saying no. Rashmi is saying always yes. Varsha is saying yes. Jaya is saying no. Suman is saying yes. So there's a lot of questions coming on. On a safer side, Anisha is one step ahead. Very good. So usually, if you are examining in front of others, it might not be like it's not a gynecological examination where you want, but preferably if the examiner asks yes, because you need a yes, I think Jaya is right, unless it invades her privacy. So that's right. So answer is basically if you're doing it in open where other people are there, you're like there you don't require. But like a breast examination and gynecological examination, yes, definitely yes. But in this, it is a kind of a unless and until privacies are hurt, you can do it, even without an examiner, like without a female attendant. But again, if for the sake of examination, you say yes, sir, preferably yes, I think that is the better answer. Okay. Next.
Sure, sir. The height was 166 centimeter with a weight of 65 kilogram. The patient was moderately built and well nourished. There was no signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. The vitals were stable. On oral cavity examination, particularly the inspection part, the
Are
head
you
was
aware that for the examination purpose, are you aware what are the vitals? If the examiner asks, probably they don't ask, but just be aware what do you mean by vitals? Okay.
shall I go into the vitals?
No,
Okay, okay, okay.
please go ahead. Inspection.
So on the inspection part, the head was upright, centered with symmetrical cranium and a small solitary round swelling noted on left side of the neck, corresponding to level 2 neck node, without any obvious skin changes. Lips and commissures were normal. The mouth opening was adequate for about 3 to 4 fingers of her non-dominant hand. The uvula and tongue.
Again, Piyush, head upright, and upright is the patient, themselves they'll do or you ask them to do. Centered. Basically, here you get the facial symmetry. There was a symmetry on the face, or there was a facial symmetry, rather than making it very complicated, upright and centered with symmetrical cranium and a solitary small round swelling. The reason why am I saying is that this kind of a language is, I can bet, I mean, how many people are there? 179 people are there now online. How many people will write in this language, upright and centered with symmetrical cranium and a solitary small? It looks like you're writing a poem, you know. So there was a facial symmetry, or you say that there was a loss of facial symmetry with a bulge on the right side or the left side. So just make it a very simple, upright and centered. This is not the language what you have to really write, you know. There was a facial symmetry, or there was obvious, there was asymmetry on the face with a bulge on the right or the left side. So write in that way. Okay.
Okay, sir.
This is a very complicated line. Okay, next.
The midline, the uvula tongue was in the midline. There was normal soft palate elevation on pronouncing syllable R. The teeth, I've tried to include the dental formula over here, that there was all teeth were there but intact. There was generalized tobacco staining of teeth, and there was also the left-sided first premolar tooth appeared jagged. There was no dental caries noted. On the buccal mucosa, a single reddish ulcero-proliferated ovoid growth of size of around 3 to 3.5 by 2 to 2.5 centimeter in the left buccal mucosa noted, with extending anteriorly around 0.5 to 1 centimeter posterior to the left commissure of lip.
Piyush, you know, don't, I'll ask anybody. Abhilash Banerjee is there. Abhilash, do you agree with the examination the way it is, or even Devanjan can answer? Anybody? Abhilash is agreeing. Abhilash, can you unmute yourself and say that will you write in this way 3 to 3.5, 2 into 2.5 centimeters? You can write rather
Hello?
than this straight
Hello?
away.
Inspection, no, sir. Inspection 3.5 to 1.
Yes, yes. So
We
give
will
one
only write
value.
one.
Yeah, just write
Some
one
fixed
value.
identity. Yeah.
And no 0.5, you know, because because this is this is an inspection, correct?
Yes, sir.
This is an inspection. So you can just write approximately 4 into 3 centimeters. That is fine. Approximately 4 into 3 centimeters, because in inspection, yes, Rashmi is right, approximately. So just give one value. 4 into 3 centimeters, 3 into 2 centimeters, approximately. That's all. No, write 3 into 3.5, 2 into 2.5. Okay. Don't make it complicated. Okay, Piyush?
The lesion was extending anteriorly around approx 1 centimeter posterior to left commissure of lip, and approximately 3 centimeters from upper left gingivobuccal circle, and approximately 4 centimeters from lower left gingivobuccal circle, and extending posteriorly up to the first molar. The slow noted on the floor. The edges appeared to be everted. The margins were looking irregular, without any discharge or bleeding. A small erythroplakic patch noted around the margin. The left cheek skin appeared normal, without any scar or sinus noted on the external part of the skin. The right.
If you have written so much, you could have written the base also. You have already written the edges. You have written the margins. No obvious bleeding. Then even the base you can write, you know.
Sir, it was the inspectory findings, so I didn't write the base over here. Sir.
Okay, now just by the look, you know, how was the book? Sluffy, non-sluffy, reddish, you know.
I've actually
Okay.
included the flow, sir. The
Okay.
flow.
Fine.
Sir, sorry to interrupt. I just jotted down, sir.
Yeah, please.
Sir, regarding the mouth opening, should we mention it in terms of 2 fingers or like that, or the exact measurement like 15 mm, 20
No,
mm,
because
like that, sir?
because he has started. This is a inspection, you know. So you can say approximately what you're looking like. Sorry, come back again. Please say me once more. What did you say?
Uh, Dr. Pish, can you go to the previous slide?
Sure, sir.
Sir, the third point, mouth opening of around 3 to 4 fingers inter-incisional
Yeah, so
distance.
I
So
think
should
this
we,
is a very valid point. Yeah, please say.
yes, sir, should we mention it like 20 millimeters inter-incisional distance or like 3 to 4 fingers? Because some examiners are telling mention it in fingers, some examiners are telling you should mention it in millimeters. So which is the ideal?
I
continues.
will say, you know, it also depends upon examiner to examiner, but if I am the examiner, if I am a student, I'll prefer to say mouth opening adequate or inadequate. That's all. I don't want to get into the complication of fingers or centimeters. Because in the moment at the fingers, it's not an inspection because I'm using something. Inspection, what I can see from the naked eye. So I have to just say that mouth opening is adequate, you know, that's all, nothing else. Mouth opening is adequate or mouth opening is inadequate because this is just an inspection. If you're using a fingers, then it is not a inspection. That I mean to say. Okay. So just
Thank
say
you, sir.
mouth opening is adequate. And
Sir,
midline uvula tongue protrusion, you know, tongue like midline uvula and tongue without deviation. So this means, what do you mean that there is no deviation of the tongue, correct?
Yes, sir. No deviation of uvula and tongue, both. Sir.
Okay, fine. Next slide.
Sir, I have a doubt, sir.
Yeah, please.
The mouth opening that I have mentioned, that the 3 to 4 fingers are the left non-dominant hand of the patient, sir. So I'm not actually using my hands per se. I'm just asking for the help of the patient's hand. So does it will
But
come
you know
under
that doesn't know because you are not mentioning that, and moreover, some examiner might get annoyed that why are you asking a patient to put their fingers in the mouth, you know? And even in the clinics, we have never done that. You ask the patient, okay, put your fingers in the mouth. You know? We never do that. You know? So it's a
Okay.
very unconventional way of explaining anything. So please absolutely refrain from that. You know? How
Sure, sir.
many times any one of us have asked you, the patient, put your fingers in the mouth and show me how many fingers are entering? No, we don't do that. So just say mouth opening adequate, not adequate. Okay.
Okay.
Hmm.
Coming up to the next slide, sir. Continuing from where I left,
Yeah.
that the gingival and gingivolabial sulcus of the tongue was appeared normal without any lesion. The alveolus, floor of mouth, the retromolar triangle, both palate, tonsil, tonsillar pillars, and posterior pharyngeal walls were appeared normal without any lesion. On palpation, no local tenderness was noted, no local rise of temperature noted over the left cheek. All inspectory findings were confirmed. A solitary ulcer proliferative growth of size 3.5 to by 2.5 centimeter in the left buccal mucosa, extending anteriorly 1 centimeter posterior to left commissure of lip, 3 centimeter from upper left GBS, and 4 centimeter from lower left GBS, extending posteriorly up to first molar, with the base of firm consistency, everted edges, irregular margin, and wasn't fixed to surrounding skin. There was also induration present up to 0.5 centimeter from the margin in all directions. The lesion was not bleeding on touch. On bidigital examination of mandible, there was no mandibular involvement felt. On neck examination,
You just go back once, you know.
sure.
Any input from anybody else? You know, do you want to add anything? Dheeraj,
Sir,
Dhruv, anybody?
sir, just one more doubt, sir.
Yeah.
Sir, is it ideal to mention the normal structures first? For example, in this case, tongue normal and antitonsil normal, and then mention the findings like the lesion, or should we mention the lesion first and then the normal structures?
Either
Like,
way,
is there any order?
either way, Abhilash, both are fine, you know. Some examiners, they want to listen the positive finding first and then they go for the next one, you know. Other examiners might be other way around. So both the ways, Abhilash, it is right. It's not an issue, you know.
Sir,
Uh,
I'm Dr. Jayakshay.
Whichever so. Hello?
Yes, sir, yes, I'm Dr. Jayakshay.
Yeah, please.
Okay. Yes.
Okay. Okay, Jaya.
Yes.
Absolutely fine.
Yes.
So both the ways it is right. You know, anything else you feel to say that anybody wants to add anything in this? I'll always say to all the examining going batch, because on Tuesday I'm sure you all will do excellent in the exams. While explaining the way the Piyush is explaining, he has done a wonderful job. On the day of examination, when you're explaining, look into the eyes of the examiner. Take your time, pause, take a take a deep breath, start explaining in such a way that examiner can visualize it. Here, since Piyush is reading his presentation, then it becomes different. But in the exam, you will not be having any paper in hand. So there you will have to imagine the tumor and then you will have to explain to the examiner. So that is only possible when you are imagining the tumor. How did the tumor look like? And then you have to make the examiner visualize it by speaking, and that is only possible when you'll be slow. Make it a point that starting ki anterior, posterior, superior, inferior, medial, lateral in a very synchronous manner so that examiner can imagine while you are saying that what is the tumor, where is the tumor, and it will be easier for him to frame the questions. So that is what I mean to say, because you will have to, many times it will happen if you have taken the history, then you have gone for lunch, you had come back, and suddenly you are called, keep, okay, please come. So now you can only have a time that you can have to imagine the tumor and then start explaining to the examiner. So take your time, be slow and gradual, anterior, posterior, medial, lateral, superior, inferior. This will be your ear, whichever way you have to begin, but make it a synchronous. It should not be like you're saying anterior, then superior, then posterior, then lateral. It becomes a totally confusing. Okay. Go ahead. Next.
Sure, sir. On neck examination, a single non-tender left-sided level 2 neck node, rounded in shape, measuring almost about 2 by 2 centimeter, with smooth surface, hard in consistency, freely mobile in nature, non-ulcerated, without any local rise of temperature noted. On ENT examination, there was no obvious lesions in the nasal cavity. Indirect laryngoscopy was not done. On systemic examination.
So 1 minute, just go back last,
Sorry,
because we'll have to say. So Kanika, Nitin, Raghav, anybody, have you all done ENT examination, ideal examination? Have you ever done? Shweta, Soumya, Aditya saying no. Fine.
Yes, sir.
Gautam Balaji and Raghav are done. Okay, fine. So basically, you have to just keep it, at least for the examination sake. It is really not that common nowadays. Shalini is saying yes, fine, good. So basically, just have a at least for examination purpose, make it a point to just see what is an ideal. And you have to just, sometimes the examiner is very curious to ask that the ideal mirror, what kind of mirror it is. It is a plain mirror. The Bull's lamp mirror, what you place it on your head, is basically a concave mirror. And the images which comes on the laryngeal mirror is always a virtual image. Virtual image means the right will become the left and the left will become the right. So that is specifically this holds true for ideal. In direct laryngoscopy, it happens reverse. Right is right and left is left. So that you have to remember. Even Hopkins examination, it remains the same. It's a virtual image, So ideal and Hopkins both are virtual images. Okay. So that, and ideal mirror is basically a plane mirror, and the the Bull's lamp mirror is the mirror which you put in the head is a concave mirror. Okay. Next.
Sure, sir. On systemic examination for the respiratory system, there was no signs of respiratory distress. The normal lung sound was heard. On cardiovascular system, the both heart sounds were normal. On hepatobiliary or gastrointestinal, the abdomen appears flat, symmetric. Bowel sounds were present, normoactive, swelled, soft, and non-tender. The liver algae was not palpable. The liver span was 6 to 8 centimeter, measured in mid
Dr.
clavicle.
Piyush, in order to paucity of time, can you just now straight away come, because it will happen in exam that people will, they know that you are doing it very well, and with last 4-5 classes, more or less everybody is knowing the basics of examination now. Head and neck was discussed yesterday also, so everybody knows it. Can you come down to the final?
Sure, sure.
What is the provisional diagnosis of this patient?
The provisional diagnosis is the probable case of carcinoma of left buccal mucosa with the clinical staging of CT2, N1 and N0, which is stage 3. So,
Okay, anybody wants to add anything? Gaya, Gayatri, Hari, Harsha, Irfan, any inputs, or are you fine? I think everybody's fine, Dr.
So
Piyush.
maybe just say malignant lesion of the
Malignant
buccal mucosa.
neoplasm of the
Absolutely
buccal mucosa.
fine. That is exactly. Can we say carcinoma? Better to say malignant lesion, Carcinoma is also malignancy of left buccal mucosa. Absolutely fine. Diagram to be drawn. Absolutely. Very, very important. Mubsireen Begum, this is something which is a cardinal. You have to draw the diagram. And please, for heaven's sake, draw a big diagram. Because when the examination, because everybody, I think 70 to 80% of the doctors' handwritings are really, mashallah, is very difficult. So I'll always say that your diagram will score above anything else. So the diagram should be really very, very big. You should see how Dr. Kanu Patro draws a diagram. Amazing. He's an artist. He draws such a beautiful diagram he draws. So always make it a very big diagram so that examiner looks at it and they understand it. Okay. Excellent. Very good. Very valid point made. Next. How will you, what investigations you'll ask? Now, can I ask this question to anybody else? I mean, go to the workup. What investigations you will be asking? Sai, Sanjiva, Shravana, Sarthak, anybody?
I'll first confirm the
Routine diagnostic staging.
Who's there? Jaya? You're Jaya?
Yes, sir.
Can anybody just, okay, Jaya, just brief it. I mean, how will you work up this case now?
So for routine examination, so for routine lab investigation, CBC, complete blood count, renal function test, and a baseline function test. Along with that, I would go for an ECG also, ECG deco. And now coming to the diagnostic workup, that is to go for a punch biopsy, or if it is an infiltrative lesion, I would go for a incisional biopsy. And coming to the staging workup, I would prefer to do both CT and an MRI. CT to rule out bone infiltration, MRI to know the extent of the soft tissue lesion, and to know the status, whether it's ENE positive or.
What advantage you get CT over MRI then?
Sir, CT scores well better than MRI regarding the bone lesion, sir, infiltration of bone lesion, which might upstage the disease.
Yeah, so I'll agree with, but see, Abhilash has responded. I think everybody has responded very well, but I agree with Abhilash because biopsy to confirm, that has to be your first thing. And thereafter you go for, because biopsy to confirm, and thereafter you can say whatever you have mentioned. Both CT as well as now. CT is very good for two reasons. One is your
Cortical erosion.
Cortical
okay,
erosion bone.
very good. So that is bony involvement, right? And nodal involvement.
nodal.
Yes. And the other MRI has an advantage of seeing the
Soft tissue, more.
Soft tissue and
Soft tissue.
perineural.
Soft tissue and perineural. Excellent. So PNI, perineural invasion, is very good.
And
Very
also,
well.
sir, early stages of bone involvement, like marrow involvement.
Early stages of narrow involvement. It becomes too, who is it Piyush who said?
Yes, sir. Yes, sir. Yes, sir.
Piyush, refrain from saying that, you know.
Okay, sir.
So don't say
Okay.
that bone involved, because then it becomes really an advanced. Don't invite problem, Piyush, you know. Be very careful in saying whatever you want to say. I'll again say ki I can vouch for it. Everybody who is attending, who is going to exam on 26 will definitely pass. I'll definitely pray. Please be very patient over there. Very, very patient. Listen to the examiner. Don't try to be over enthusiastic. Listen to the examiner. Be very patient. Your answer should be very short and crisp. If you know something very well, still don't start getting jumpy. You prepare in such a way as if it looks you are recalling and answering, even if you know it very well. Whatever the examiner asks, answers only up till that, then wait a bit. If you have answered something which is wrong, examiner makes a face, annoyed face, just says, I'm sorry, sir. If examiner says, do you know? And if you really don't know, say, I'm sorry, sir, I am not sure. If he says, ki, please guess, then you do guess. If he says, ki, are you sure? If you're not sure, be very honest and say, no, sir, I'm not sure. And if you've committed a mistake, then just be very patient to say, I'm sorry, sir, because this will help you to get the next. And if you've done something, I don't know, don't hesitate in saying, sir, I don't know, I'm not sure, sir. Okay. Examiner loves that answer because what it shows your honesty. Because next question can be the one which you are knowing it. So don't try to keep a long guesses. And there will be something where examiner, you will, very simple thing and you are not able to recall. And if examiner is giving lot of hint, and then so don't make those faces, oh shit, don't make those noises. Say, "Ki, sir, I knew it, sir, I completely, sir, I missed it. I'm so sorry, sir." So examiner very well knows that ki, what you can miss and what you don't miss. So be very honest with that. Okay. So diagnosis part is fine. How will you manage this case? I'll ask somebody else. Rubia, Rishabh, Richa, Sai. Sai is silent all the way. Shalini.
So it looks an operable lesion, so we will
Very good.
send him to the surgeon.
Nitya. Okay, very good. Fine. Shikha, Shivani, you agree with Sai? I mean, agree with Aditya? Yes, everybody is agreeing to it. Now,
Yes, sir.
say me one thing, surgery has also been done. One person, Shivakumar or Shivaranjani, anybody. What is the indication of adjuvant RT in a CA buccal mucosa patient you're sitting in the OPD? When you will give this patient
Sir, T3, T4 disease,
okay,
node positivity, sir.
node positive.
LVI positive, sir.
Okay,
PNI positive, sir.
okay. Now I think T3, T4, it was a T2, it's a LVI positive. Will you give radiation?
Sir, T2, sir, yes, I'll take a radiation, sir.
Yes, sir. Node is positive, so we can go for radiation.
Rashmi is right, node positive. No, so even Aditya also mentioned regarding the node positivity. He did mention. Okay. What is an absolute indication for giving radiation in a post-operative case of a TA buccal mucosa? One by one.
Positive.
Positive margin.
Sorry.
Positive margin.
Right. What is right? T3, T4, positive margin, node positive. So these are absolute indications of giving
Yes, I.
adjuvant RT. There are some soft indications and there are absolutely indications where you have to give. So T3, T4 you definitely give. Node positive you definitely give. Margin positive you definitely give. ENE positive you give. You know.
So
So there
depth of invasion more than 10 mm?
So that is a T3, no? So if it's a depth
T3,
of
yeah.
invasion, yes, it will
Yes, sir.
become a T3 by any virtue.
sir.
So
Sir,
now,
worst pattern
the
of
more than-
invasion 5.
So what's see? So those are soft indications if you say, because worst pattern of like there are some soft indications like LVI positive and worst pattern of invasions more than 4 or 5, you know, in them. And if it's even it is a T2, then it becomes a situation where you can give. I'm asking the absolute indications only. And examiner will not be trying to test you so much that T2 and depth of invasion was only 7 mm with WPI of 4. Will you give it or not? Because the entire world is divided on that. So why they'll ask something? They'll ask something which is absolutely very clear. I'll ask Simran or Shivakumar, these two people, if they're listening, when you'll add chemotherapy? When will you add chemotherapy? So Rashmi and Anisha, everybody is right. Margin positive and ENE positive. Can you margin positive and ENE positive? You'll be giving chemotherapy also. Absolutely correct. Dr. Kanun, here everybody knows everything. So I don't think so we have much to teach. Everybody is knowing. Kanu is there?
Sir,
And-
one doubt, sir.
Yeah.
Hello, sir.
Bernier and
Sir,
Cooper, I think Imran had mentioned, yeah, so those two trials, Bernier and Cooper. Bernier was basically EORTC trial and Cooper was RTOG trial. Okay. Bernier is EORTC. Bernier and RTOG is Cooper. And for remembering, it's always B is followed by E. So Bernier is EORTC. Okay. So naturally the Cooper will become RTOG. Okay. Abhilash, yes, Cooper RTOG 9501. Yes. Yeah.
Sir, one doubt, sir.
Please.
Sir, after history taking, like preceding the examination, should we give a history summary separately or should we give the case summary as a whole after the examination? Some case presentations I have seen, they gave a summary after the history taking.
After the history taking. Usually after the history taking. It might happen.
Okay,
I think the question was asked by Jaya, right?
Yes, sir. Yes, sir.
Yeah. So Jaya, what happens usually, examiners are also, for the exam, you don't know that whether you are the first student or you are the in between or you are the last student. Examiner might sometimes just keep that thing. So what is the summary of your, then You have to straight away go, or if you are a first student, examiner has all the time on the world to listen to you, complete the entire thing, and then you say the summary. So it usually advocated at the end. Okay.
Thank you, sir.
Fine. Thank you so much, and God bless you all. All the best for the exams. Again, I'll say I'll just share my last experience. I had given my DNB in CMC Vellore, and I still remember such a simple question which 166 people are there, and I'm 101% sure 166 people they know this answer. My question, which was asked by Dr. Ramesh Billy Magga sir, "Hey, Tanvi, so it was a long case of a CA breast, and I was asked that patient has completed surgery, you have given radiation, now patient is going back. What further treatment are you going to give to this patient?" I was stunned and I just kept quiet. I told, sir, I'm not sure. Sir, I told physiotherapy, this, that. He told, Tanvir, it is a drug. It is a drug which is being given. What is that? Then again, I was mum. He told it is an oral drug. Are you? Again, I was mum. He told, when he got a bit annoyed, he said, okay, now you are irritating me. The last hint I'm going to give is, it is based on the receptor studies. And then I realized how big foolishness I was doing. So I told, sir, ERP, sir, tamoxifen and hormonal therapy, sir. He told that, absolutely. And he smiled at me. That still I always remember, examiners, believe me, they never want to fail us. They want to pass you. They just look for some one or two answers, then they want to pass you. So they don't try to test you. They treat you like your own, very own students, and they just search every possible way to pass you. So please go with that positive frame of mind. I will pass. It is not that it is because you deserve to pass and examiners are really willing to pass you. So with this faith, you go, sleep well, take your have faith in yourself. If your apron has any kind of a hospital logo, don't wear that apron. Try to be very silent on that day. Well groomed, proper black shoes, well polished. Be very ऐसा लगना चाहिए कि तुम उस दिन गरीब हो, वैसा शक्ल बना के जाना. That means you are confident, but you are not overconfident. Listen to the examiner, look into the eyes, give a small smile, but be very gentle. I'll pray you all will pass, and no doubt about it. Okay, just carry on. Thank you so much.
Sir, there
Thank
was
you,
one
Tanvi.
query, sir.
Yeah, please.
Please
So
go ahead.
what is the role of PET CT scan, sir, here in a
Yeah,
buccal mucosa?
so couple of reasons. Absolutely right. So usually when we say PET CT scan, the advantage of PET CT scan is, so number one is for any imaging, you can always say the imaging takes care of the local, the loco-regional, and the distant metastasis. In PET CT, it is very important that it is not only giving you local and loco-regional, but it is giving, it is ruling out a distant metastasis. PET has a very high negative predictive value. That one word we always remember, negative predictive value. So if PET CT says that there is no distant mets, there is a very, very, very high chance that there is a no distant metastasis. On the contrary, if the PET CT says there is a metastasis distantly in the lungs, there can be that in our subcontinent, it can be tuberculosis. But if it says that there is no distant metastasis, so you are sure that there is no. So advantage of PET over other imaging is that since it has a very high negative predictive value, it rules out distant metastasis. Having said that, it also has two other advantages. It gives a very good about the nodal volume, the nodes, because amount of uptake in the SUV also decides at what kind of a node it is. SUV uptake, more intense is the uptake. You know that what is the characteristic of that particular node, because there are studies now. I'm not talking about buccal mucosa, but there are studies where depending upon the SUV value, even you try it in a radical cases, you boost your neck with the higher doses, So the neck node, and also in the cases, it also gives you a fair idea about the PNI. So in the examination, if the examiner asks, you have a PET, will you like to do? You always say it's a CT and MR, I will prefer. But yes, sir, PET has a very high negative predictive value. So for ruling out distant metastasis, we can do it, but I will still, sir, I'll be doing a CT scan and MRI. So examiner knows that this child or this boy or a girl, they know about it. Okay. So this will be the answer.
Yes, sir.
So
Thank you so much,
one
sir.
doubt, sir. So
Yes,
one
ma'am.
doubt, sir. Sir, when is cranial nerve examination mandatory in head and neck cases? For which cases should we, like in buccal
See,
mucosa? Here it's not done. Yesterday tongue also, it was not.
no, but in tongue you have to know about the. I'll do one thing. I'll prepare a short summary of the nerve and I'll put it in the group. But for the tongue, it's important, you know.
So tongue, oropharynx, and nasopharynx, we have to do all cranial nerve examinations. No, sir. Only three it is mandatory. Others we can overlook it, sir.
Absolutely, absolutely.
Okay,
But
sir.
I'll prepare a summary and I'll put it in the group. Okay, by today night.
Please, sir.
Okay.
Please. Thank you, sir. Thank you so much.
Thank you so much. God bless.
Thank you, sir.
Thank you so much, sir. Sir, I myself consider lucky that I was the part of this OSCE preparation MPRO practical
No,
for the
man.
1 week.
You
And
should.
sir, I may have done some mistakes,
No,
but
you're
I
wonderful. You're
damn
wonderful.
sure, sir. Thank you,
You've done
sir.
fantastic job. Great. God bless. Okay.
The next time I'll be much more prepared so that the mistake that have happened today won't happen in the near future by me or any other examinee who have
No,
watched this
there is
video.
no mistake. It's absolutely perfectly fine. Perfectly fine. Don't worry. Okay?
Thank you so much, sir.
Always appreciate yourself. Don't try always to cross yourself. You know, you all are wonderful. You are taking a volunteer. That itself you are a winner. Believe me. Okay.
Thank you so
Thank
much.
you so much. Take care. Bye.
Okay, I'd like to thank Tanvir sir for sparing his valuable time from his very busy schedule for moderating the session. And you have very well highlighted all the vital points and given tips to the residents. I think and I feel that they'll be very much valuable for the exam going residents or all the residents. Thank you, sir. Okay, with this, I think we have come to the end of this today's session. And please log on to tomorrow's session sharp at 7 p.m. Thank you all and good night.
So thank you so much to all the interest present here. Thank you so much for your consistent support. So with everyone's permission, I'm ending the session enough for today and looking forward to host you again. Thank you so much.